I'm going to go ahead and get started with our next speaker. Our next speaker is Dr. Powell. She is the Associate Program Director for the Iowa Medical Education Collaborative Psychiatry Residency Training Program at Mercy One in Des Moines, Iowa. She is an outpatient psychiatrist with a focus in treatment-resistant depression and anxiety. Dr. Powell got her DO from Des Moines University College of Osteopathic Medicine and completed her residency at University of New Mexico Psychiatry Residency Training Program. So we're really grateful for her to be able to come and talk to us today. And Dr. Powell, take it away.
Hi, thanks for having me. A little bit of feedback there. Let me see. Turn off my. Can you hear me okay?
Oh, sorry about that. I can hear you on my end, but we are going to need to make a couple of technical adjustments.
Okay.
Zoom can hear you, the room can't. How's that? If you like, though, you can go ahead and request a screen share, and we'll give you the.
Nothing coming out of here. Thank you.
Thank you. All right, Dr. Powell, we can see your screen. Can you go ahead and talk first, see if we can hear you?
Okay, testing.
Yep, sound great.
All right. So thank you for having me. I can hear myself speak about a couple seconds after I've actually spoken. So I'll try to navigate around that as best I can. But we will get started. So I'm going to talk to you about transcranial magnetic stimulation, also known as TMS. Before we get started, just know that I have no financial conflicts of interest, but there are several different kinds of TMS machines. I am most familiar with NeuroStar TMS, so I talk about that more. And then also we will talk about some potentially off-label uses of TMS, but it is FDA approved for major depressive disorder. And then deep TMS is a kind of TMS that is FDA approved for MDD and OCD. So our objectives today are to talk about the different kinds, also the mechanism of TMS, then the process, risks, and benefits, so that you may be able to have this conversation with patients and think about who might be a good candidate for TMS. So here's a little bit on the history, just to give some background. The first TMS device was made in 1985, and it was studied extensively in a lot of different ways, and eventually gained FDA approval in 2008 in the US for major depressive disorder. It has been used a lot more since then, as we've had even more research, and then insurance companies started to cover. And then now by 2018, so many treatments have happened. NeuroStar, one particular company, had 1.7 million treatments completed by then. And they keep some data on the treatments that are done as well. So a huge data base. So what is it and what is it doing? So this is a picture of the NeuroStar magnetic coil. So it delivers magnetic pulses directly to the person's head. So it's the same type and strength as an MRI. Similar strength, I should say, but it's placed directly on the scalp, and it delivers these magnetic fields. It has a penetrance of about 2 to 3 centimeters into the brain, and it is directly stimulating circuits. So basically in physics, right, whenever you have a magnetic field, you have a perpendicular electric field. So the brain being electricity, those circuits are stimulated. Through a lot of research, it was found that the left dorsolateral prefrontal cortex is associated with depression. So that is specifically where we target our treatments and find improvement in. Did something happen? Okay.
Can you share screen again?
Yeah, let me try that.
We can still hear you great.
There we go. How's that? Are we back?
Yep, that works.
Can you hear me?
Yes. Not on Zoom. No, this is, I'm sorry, it's still muted on that, so you can, if you. Okay, now we're good. Sorry about that. Okay, we're good now.
Okay.
And we shouldn't get that feedback anymore.
Okay, all right. And everybody can hear me just fine now on Zoom and in the conference.
Yes. Yes.
Okay. All right. So we were talking about what TMS is doing. And then to give you a little bit of an idea of how exactly that is helpful, here is an example of PET scans on a depressed brain versus a non-depressed brain, right? So even though we're targeting the left dorsolateral prefrontal cortex that is connected to all kinds of circuits in the limbic system, and, you know, with a depression, a clinical depression, you're seeing a lot of vegetative symptoms, for example, and problems with concentration. You really see that the whole brain, but targeting this area can get things going again, working again. In a different way than antidepressant, but they're doing it through increasing the neurotransmitters in the synaptic cleft and changing the number of receptors on the neurons to get those circuits working. This is doing it through direct stimulation. And then a little bit more about the mechanism that is interesting. And this, you know, is something of a lot of research, including on antidepressants, of what exactly is happening to strengthen some circuits versus others or downregulate others. So maybe of interest to you, I think it's really cool anyway, is this video on long-term potentiation. And it's just an example of how different circuits can be strengthened. So let's go to that. There's going to be a little bit of an ad first, so sorry about that.
So now I'm going to show you how things
Okay, so the end.
Welcome to Intermittent Neuroscience, where I explain neuroscience topics in Intermittent TMS. In this installment, we'll discuss long-term potentiation, or LTP. Process how synaptic connection between neurons becomes stronger through activation. LTP is thought to be a way in which the brain changes in response to experience, and thus be a mechanism of memory.
plays something funny. Okay. All right, so the idea is that, and this is just one example of how this happens, how certain circuits in the brain get more sensitive and more likely to fire than others. And this is happening throughout the brain in a lot of different ways with mechanisms that we don't even really know about. That this is responsible for learning, for things like in trauma, generalization of fear triggers to multiple things instead of just being one trigger, for example. So it's a very interesting area of research. So there's thoughts as well that TMS, and not just doing the direct stimulation, is also having more long-term effects on neuroplasticity. So this is an example of a MagVenture TMS machine, and it's a new machine that does simultaneous functional MRI. And so the idea is this is Navigational TMS, and even before this new MagVenture machine was created, TMS was just being used to map the brain using functional MRI. See what areas are connected to what, if we stimulate this part of the brain, what do we see on the MRI? And now, because we try to target specific areas for treatment when we're using TMS, the functional MRI can be helpful to make sure that we are stimulating the correct place. There's also recurrent TMS, and so that is what I'm going to talk about the most. That's the treatment for major depressive disorder and OCD, and there are a couple kinds of that. Here is a picture of deep TMS. So deep TMS uses, it's recurrent TMS as well, meaning that there are multiple treatments in a row to get the desired outcome. But deep TMS has a different shape in the coil that leads to being able to have an effect on deeper structures. So in that 3 to 5 centimeter range. And there's been more research on that for OCD, and it has been approved for treatment of OCD in addition to major depressive disorder. Then there's also Theta Burst Stimulation, which is a kind of recurrent TMS that is used to treat major depressive disorder. And that was approved in 2018, but it's getting a lot of attention and research right now. There was a study that showed it can decrease suicidal thoughts independent of depression response. So that can be useful for patients admitted to the unit. It's not really something that's happening just in the ER, but could help with suicidal thoughts in somebody who's admitted in the hospital to help decrease those thoughts over the span of a week or so. So this is the standard protocol we'll talk about. I'll describe exactly what theta burst stimulation means too, but this is the standard protocol for treating major depressive disorder. So we're focusing on the left dorsolateral prefrontal cortex, and that is delivering 10 pulses of this magnetic field per second for 4 seconds. And then you have an interval of 11 seconds and then repeat until there's a total of 3,000 pulses delivered per treatment. And that takes 18 minutes and 45 seconds to deliver these 3,000 pulses for one treatment session. And then patients come in and have this done 5 days a week until they've had 30 or more treatments. There are a lot of different, ideas of how long to continue to do this, and, titrating off or maintenance TMS. Honestly, how many treatments we're actually doing is often determined by the patient's insurance, how much they're willing to cover. And on average, it seems to be about 36. And then if somebody is showing a treatment response partway through their treatment, then I personally like to do a titration off. There is some evidence that titrating off, like doing 3 for 1 week, then 2 for 2 weeks, 2 per week for 2 weeks, and then on, can increase the time before recurrence of their depression. So here's kind of a visual graphic of what this looks like. Try to make that bigger for you all. So this is the 10 Hertz protocol for 10 pulses per second for 4 seconds. This is actually old, where they had a 26-second interval. Now that's been reduced to 11 seconds because we know that is safe. Why not do it faster? And then, another pulse train and repeat, repeat, repeat. Okay, and then this is an example of what intermittent theta burst stimulation is. So there's 3 pulses at 50 Hertz clustered together in bursts of 5 Hertz. And that's taking course over 2 seconds within an 8-second interval. And so those treatments are actually done in about 3 minutes. And the protocol for suicidal ideation had you doing these 3-minute treatments with a gap of 15 minutes in between, and you do 5 per day, 3 days a week, to get the results for suicidal ideation. And then the deep TMS does the same 10 Hertz protocol, but it's just the different coil where it looks like a helmet, and it's getting to deeper structures as well. There is another protocol that is the Onehertz protocol, and that is over the right dorsolateral prefrontal cortex. And so the question is, why would you choose right instead of left, 1 Hertz instead of 10 Hertz? The 1 Hertz protocol takes 50 minutes to complete because it's just 1 pulse per second, and there is no interval space in there. So it's just the constant tapping 1 per second for 50 minutes to get the 3,000 pulses in. There is data supporting it's useful in generalized anxiety disorder and PTSD in addition to major depressive disorder. So it's thought that stimulating the right side instead of the left side is actually more inhibitory than excitatory. So that could be beneficial for people who have a large anxiety component with their comorbidities or with their depression. But at the same time, it has been found to be helpful for depression, so it could be a good alternative. Personally, if I have a patient who gets a lot of pain from the regular protocol, then I will switch to the right side. Also, sometimes patients feel really activated with the left-sided protocol, similar to how people can get too activated or irritable with certain kinds of antidepressants, and that would be a good reason to switch to the right side. Now, this is a description of how we actually start this, right? So every patient has to have individualized treatment because we have to find the left dorsolateral prefrontal cortex on each patient. And then we also have to find how sensitive their brain is to the magnet. So, and then sensitivity to the magnet can vary a lot person to person, and that kind of depends upon age and brain health. We don't really know. It depends on what medications they're taking, how much sleep they get, caffeine use, all of these things. So we want to personalize that as much as possible. So how do we do this? Well, first we put the treatment coil not over the left dorsolateral prefrontal cortex, but we put it over the primary motor cortex. So we have our favorite homunculus picture there for you all to enjoy. So we want to find the place in the primary motor cortex that causes the hand to twitch. So if we're doing this on the left side, we're going to expect to see the right hand twitch, okay? And so in doing that, we can find the motor threshold. So that's the strength of the magnet necessary to cause movement 50% of the time. And that's what really varies person to person. And even if their medications change, that can change. We want to make sure we know what that motor threshold is for that specific person. And then also, if we can narrow it down to the part of the primary motor cortex that controls specifically the pincer of the thumb and the index finger, then we know that the dorsolateral prefrontal cortex is 5 centimeters anterior to that. So we use this mapping process to find the strength of the magnet needed and also the location necessary. And different machines have a little bit of different means of going about doing this. The MagVenture, for example, every patient wears a cap and you draw on their cap and make note of where you want to put it, and you can do measurements and everything, and then you place the coil over their dorsolateral prefrontal cortex. The NeuroStar has instead all of these settings on a headrest that you just keep the same exactly treatment to treatment to treatment, and measurements of where to put the coil, so that, you know, you're expecting that you are using the coil in the same location every time that they have a treatment. So let's talk about safety of TMS. It is okay to take on medications. As I mentioned, medications can affect the motor threshold. So you want patients to not have a significant change in their medications while they're doing TMS, because that could change what their motor threshold is or their sensitivity to the magnet. So the main concerns, safety concerns for this, are seizure, or if they have any ferromagnetic substance in or around their head. So if we understand that this magnetic pulse is inducing electric activity in the brain, well, too much of that can turn into a seizure. So this is really part of why it's important to find an accurate motor threshold for these patients. We don't want to be giving them a stronger magnetic pulse than they need. That said, seizures are very rare. And for the patients who've had seizures, oftentimes there is a risk factor, like, you know, decreased sleep the night before or something like that. And we do not do TMS in patients who have ever had a seizure or who are at high risk of a seizure. But just in case, we do have staff trained in seizure response during the entire treatment. So the way this works in real life is I would do the TMS mapping session, and then for the 5 days a week treatments, medical staff does the treatment and they sit in the room with the patient the whole time. So that can be an RN or a CMA. And then other things to take into consideration for safety, you know, obviously this is like an MRI, so we don't want any metal that will respond to a magnet. And it's not as extensive as an MRI, like it only needs to be within 30 centimeters or about 12 inches from the treatment coil, that there should not be any metal. So, you know, if people have had surgery, pretty much shoulders or below, they're going to be okay. It does make that loud clicking sound that people experience in an MRI as well. So we all wear earplugs to avoid hearing damage. And then most commonly, what happens in terms of side effects are headaches in about 50% of patients. Also, there can be pain or irritation at the treatment site. That is very common, especially at the very beginning when people first start the treatment, but that tends to get better as people have more and more treatments and it doesn't bother them anymore. It is okay to take, you know, whatever standard headache medication after the treatment. So I recommend that people take some Tylenol or ibuprofen if they have a headache afterwards. So contraindications, I mentioned, is seizure disorder or increased risk of seizure. So you want to be screening your patients for eating disorders, substance abuse, or a history of a severe TBI that would increase the risk of seizure. Obviously metal, need to ask about that. And then we don't want our magnet to interfere with pacemakers or defibrillators. Let's talk about efficacy. Just like an antidepressant, it takes about 4 weeks to notice benefit from TMS. And then in terms of treatment response, you know, the numbers vary, but there's one particular study that is about, you know, consistent with the other studies out there, but this study looked at people a year later too, so that's interesting. This particular study found that after the acute series of 30 treatments, 41% achieved remission of their depression, and then 62% responded, which means a 50% reduction in their depression scale scores, okay? And then they followed this same group over a year, and they found at 1 year, remission rate was 45% and response rate 67%. However, 36% of these patients had their depression come back and had repeat TMS, but they didn't necessarily have the whole course again. They had a mean of 16 additional treatments. But we're seeing, for the rest of those patients who had remission, that they were still depression-free at a year. So when do you consider TMS for patients? So it really has been studied almost exclusively in patients with treatment-resistant depression. Now, what that means, how that is defined, is going to vary between different studies, but generally looking at 2 to 4 antidepressant trials in at least 2 different classes of antidepressants. And those antidepressants need to have been tried for an adequate dose and duration. And we're looking at 6 weeks, really. You will have patients, however, who are categorized as treatment resistant in your practice who maybe didn't have the adequate dose and duration, but they were just not able to tolerate antidepressants. And TMS could be a good option for them. Of course, when you're looking at treatment-resistant depression, you want to make sure that they're not using substances that could be contributing to that, and medical conditions have been ruled out and treated. A lot of you, I'm sure, are familiar with STAR-D, which is a study done looking at a potential treatment algorithm for depression, looking at remission and response rates for depression. And here's some interesting data from that. So what they did is they, randomized patients into a lot of different groups. And their first step was to give patients citalopram and look at the remission and response rates for that. So with just a trial of citalopram, and these are patients just having citalopram without prior antidepressant trials, the remission rate is about 36.8%, in this study. And so that's even less than we're seeing with TMS in patients who are treatment resistant. And then if those patients didn't get better from citalopram, the remaining patients were then taken to step 2. So they were switched to a different medicine, like bupropion, sertraline, or venlafaxine, or they were switched to CBT, or they were augmented with bupropion, buspirone, or augmented with CBT. And in general, lumping the data together, the remission rate for all these people in step 2 was about 30%. Then for those who did not get remission from step 2, they moved on to step 3, where they were switched to mirtazapine or nortriptyline, or they were augmented with lithium or T3. And there we're seeing a remission rate 13.7%. Finally, step 4 was a switch to tranylcypromine or venlafaxine plus mirtazapine. And the take-home point with this is that the remission rates are not great with antidepressants, period. And also, as you have more and more trials of medications, the remission rate goes down. So we're finding these treatment-resistant patients here. And there's actually quite a lot of treatment-resistant depression out there. Most people don't follow this exact algorithm, but a common strategy is to try 1 or 2 SSRIs, maybe an SNRI. If there is some response, it's a good idea to augment. If there's no response, it's a good idea to switch. And these are all medications, except for we don't really use tranylcypromine anymore, but these are all good things to try for your depression algorithm. So where does TMS fit in with this? It is a very time-intensive treatment, right? People have to come in 5 days a week to get this done and use this expensive machine. So it's a lot cheaper to use medications, but the remission response rates might be better with TMS. So you're finding that people will be going to TMS. Hold on just a moment, more technical difficulties. There we go. So we'll find that we're using TMS sometimes after The minimum would be 2 antidepressant trials, but oftentimes patients have had 4 or more. So in terms of some of the other treatments for treatment-resistant depression, you are going to use TMS before MAOIs, right, because of the high incidence of side effects, the risks, and especially the difficulty adhering to the MAOI diet, right? And you are going to use TMS before ECT because of tolerability and ease of administration. And you are going to use TMS before ketamine because ketamine does not have as much data backing it up, is less available, more costly, and does have a higher incidence of side effects, although they are generally fairly well tolerated, even if patients are having dissociation from the ketamine. So with patients coming to me for a TMS consultation, they often haven't tried any of these. Sometimes they have tried some of these, but often I want to make sure that the diagnosis is correct, that they don't have a bipolar disorder or a medical disorder or untreated ADHD or a personality disorder that could be contributing to their treatment depression, and then move forward with TMS. About how to learn more about TMS and get trained in this. Many residence programs do have a TMS program. There is not any specific coursework or certification that you have to do at this point to be able to do TMS once you graduate from residency. But, you know, if your program has TMS, I would encourage you to specifically look at how to evaluate if somebody is a good candidate for TMS and how to discuss this with patients. That's kind of the bulk of what's different about it from regular antidepressant treatment, is identifying the candidates and then being able to discuss what the treatment is like for them and what they can expect. As far as the machine itself and how to use the machine, there, you know, just so many machines out there that you really want to be trained on the specific machine that you plan to use and be familiar with the protocols for that machine. That can really vary a lot machine to machine. So, for example, I mentioned the Mag Venture. That one has a lot of flexibility in how you can use it, and you can create your own protocols for how to use it. So that's really good for doing research or doing protocols that might still be somewhat experimental, not necessarily FDA approved. And then there are some machines that have pre-programmed into them what the protocols are. Like NeuroStar, for example, has the 10 Hertz left dorsolateral prefrontal cortex protocol programmed into it. It has the 1 Hertz right dorsolateral prefrontal cortex protocol programmed into it. And it also has the intermittent theta burst stimulation protocol. It's you know, user-friendly, but less flexibility in what you can do with it if you want to do different kinds of protocols. So what this looks like in practice, if you want to be a TMS provider, so obviously you have to set up your TMS program, you have to recruit patients for this. You're going to be looking at treatment-resistant depression patients. So it's kind of part of having a treatment-resistant depression focus in your practice. It's really helpful if you have somebody on your team who will be a point person to initially do the screening of patients interested in TMS. So to make sure that, you know, they're not wanting it for schizophrenia or autism, or that they don't have seizures, and explain that to them. And then also a big thing is the questions about insurance covering it and cost. So it's really helpful to have somebody there who can do the initial discussion with patients about all of that. And that would then leave the evaluation for the psychiatrist to see if a patient is a good candidate for TMS, that it's likely to be helpful for them, that they don't have any contraindications, and the psychiatrist can really go through the informed consent process. Then after that, you have to do the prior authorization. And we are finding that most insurances are covering this. So at least in Iowa, you know, Medicaid varies state by state right now, but in Iowa, Medicaid is covering it, Medicare is covering it, and most of the private insurances are covering it as well. They have different requirements for what patients have to do before they can get TMS, like how many medication trials and therapy and all of that. So that's part of the process of learning how to have a successful TMS clinic. So after they get the approval for TMS, then they do the mapping with the psychiatrist. So I explain how with me, I do the mapping where I find the primary motor cortex and the motor threshold for the particular patient. And then they have their very first treatment right after the mapping, and 5 days a week after that, administered by a trained RN or CMA. It's important to have the seizure response protocol just in case, which means that a psychiatrist has to be on site at all times. And then if a seizure does occur, this is something that has to be reported. So the different machine manufacturers actually are the ones who gather this information and then report the seizures and keep track of how many seizures there are, how often this is happening, and what any risk factors could have been that led to a seizure. For my patients who are doing TMS, like I said, I do the mapping, and then after that, I check in with them about once a week to see how they are doing. As I said, it can take about 4 weeks for them to notice any benefit. Sometimes it happens sooner than that. And then also there are late responders who are more responding around 5 or 6 weeks. And so if we have on average 36 treatments per person, that's a 7-week total. So we're seeing it usually about 4 weeks in, but some people will have their response 5 or 6 weeks in. So we have our patients do depression scales every week to track that in terms of the numbers, right? So the 50% improvement in their score is a response to TMS. And so if we're seeing that by about treatment number 20, then that's when we would go ahead and start to think about, okay, this is going well. We expect to see even more improvement, potentially remission of their symptoms. And we're going to plan to potentially even titrate them off to have sustainability of their improvement. And then after they're done with TMS, it's important to have follow-up care. So I discussed how it's okay to do TMS even while patients are on medications, and most patients are on antidepressants while doing TMS. They're usually only not on antidepressants if they can't tolerate them. It is not standard procedure to discontinue antidepressants before TMS. That could destabilize patients. So the follow-up care is about, well, what now? Sometimes patients may want to titrate off of their medications, or they may want to continue them and just have follow-up care to make sure that they continue to do well with their depression. I have had cases where patients did want to come off of their medication after TMS once their depression was in remission. And just like with any patient who has recurrent depression, there's the risk that if you come off your antidepressants, it's going to come back. That seems to be the nature of a recurrent major depressive disorder. So for patients who have had multiple episodes, we generally tell them stay on your antidepressant. And then if a patient has only had one episode, then maybe it's a good idea to have a trial coming off of antidepressants so you don't have to be on it your whole life. But that said, a lot of patients do want to come off of their medications when they're feeling well. So it's important, if they want that, to follow up with them closely, to do it slowly and carefully and make sure that you're having good follow-up and check-ins to make sure that their depression is not coming back. TMS, the studies have only been on patients who are taking antidepressants. So this is not supposed to be a replacement for medication. It's supposed to be an augmentation strategy. And that is true for OCD as well. I think sometimes the advertising can make this seem like an alternative to medications. I mean, the benefits are that it's not having any systemic influence on patients like medications do, but it really is supposed to be an augmentation treatment. All right, that is my presentation. I have a number of references on here. There are also, in addition to these references, a lot of studies still on TMS for things like bipolar depression, mild cognitive impairment. I mentioned some evidence for generalized anxiety disorder and PTSD, but those have not gotten any FDA approval at this time. All right, we have some time left, so I will open things up to questions.
Hi, I'm a third-year medical. My name is Donna. I'm a third-year medical student in YIT. Something I was just wondering about was, thank you for the really nice presentation, by the way. I thought it was really interesting. Was, do you see it being TMS being expanded to taking care of other illnesses, or do you feel like it's more of like, where do you see it kind of going in the future, and what do you think personally it can be applied more than it already has been, if that makes any sense?
Yeah, absolutely. An interesting question, and I think it's an area of a lot of research. I think it's been studied in addition to psychiatric disorders. It's been studied in some neurologic disorders like seizure and migraine, but I don't necessarily know what evidence has found yet for those disorders, but there's definitely the potential for usefulness there. Some limitations could be the like how far it's penetrating into the brain and what structures it can access. So I think one area of future resource is coming up with coils kind of like deep TMS that can access deeper structures, but then at the same time with the deep TMS, you are losing a little bit of that pinpoint localization that you get with the other kind of treatment coils. But definitely that's an area for growth, is coming up with different kinds of coils. And then a lot of interesting research, I think definitely more for generalized anxiety disorder and PTSD would be incredibly helpful, especially since we have some preliminary evidence that at least the low frequency TMS could be helpful for that. It is, like I said, also being studied for bipolar depression, which can be even more difficult to treat than your treatment-resistant unipolar depression. And a lot of those patients don't have a lot of options, especially since they have to be on mood stabilizers and the antidepressants can be destabilizing. So TMS could be a really good option for them. I will say that TMS is not indicated for anybody who has any kind of psychosis. So it doesn't usually get approved for people who have MDD with psychotic features or people who have bipolar depression, like I already mentioned, but especially if they're psychotic. There has been some research into that suggesting it could still potentially be helpful for those patients. I think in some ways TMS is being looked at as an alternative to ECT because of the potential side effects for ECT. So if we could have TMS that treats all of the things that ECT does, then that would be great, right? Psychotic disorders, catatonia, but we're definitely not there with TMS at this time.
Thank you so much.
Yeah, you're very welcome.
Hi, thank you for your talk. I was curious if you could talk more about, I guess the newer, like the Theta Burst TMS and how that works exactly, because I think I read a paper about how in Stanford they're doing the bulk of the research on that and how it could reduce the treatment time to basically like 6 days or so versus.
Right. And so some of the appeal of the Theta Burst stimulation is that you can get a full treatment in within the 3 minutes instead of the 20 minutes. So in that way, it's thought of being a replacement for the current TMS protocol. But the research that was done looking at suicidal ideation had people having 5 treatment sessions per day, 3 days a week. So you can really pack in a lot more pulses per day than for your regular TMS protocol. So that's how I think they can get response is a lot faster. But in terms of how that's working, I'm really curious about that as well, because, you know, same with antidepressants, normal TMS takes 4 weeks or longer. So we're figuring that there's some changes happening besides just direct stimulation of the circuits, right? Maybe there is something happening in terms of the neuroplasticity, receptors, that is leading to that taking so long, right? About 4 weeks. I wonder how the theta burst stimulation is working differently that it can have an impact so soon. But I don't have that answer.
So my name is Agnes. I am a second year at Chicago College of Osteopathic Medicine. I'm just wondering how, I know this is kind of new, but I'm wondering if there's been any long-term types of studies, and specifically you mentioned like the headaches that people have, and I'm just wondering if those, you know, they're not too bad of a deal, but could those be something that we're concerned about in the future or anything like that, or if there's been any looks at like long-term effects of using the therapy?
Yeah, a lot of people ask that question for me. Patients are concerned about long-term effects. You know, is this doing something to my brain? What's going to happen years down the line? And, you know, we don't have any data of this causing any long-term problems. I'm not sure how far out the studies have actually gone, but this has, you know, been FDA approved since 2008. So we're seeing patients that have had this done for 14 years, you know, potentially 14 years ago, and not seeing any long-term issues. The headaches tend to be really just for that day, not like a constant thing throughout their TMS treatment. Really, I see a couple kinds of headaches that people can get. So it's interesting, the magnet can actually tense the muscles in the scalp. And so that can cause tension headaches, and that's really what we're seeing. Less likely, sometimes it can trigger migraines in people who already get migraines, okay? And so sometimes I've had to vary things a little bit for those patients. You know, it's worth it to them to do it, but they might have to take days off here and there for migraines. But I don't think there's any study looking at it, but just from my experience, it hasn't seemed to make, you know, the long-term migraine disorders that these patients have get better or worse, if that makes sense. Okay. But as far as the tension headaches, that seems to just resolve after they sleep. And then they don't have those anymore after they stop TMS. Every once in a while, I'll have a patient where the tension headaches really do bother them, and they do a lot better with the right-sided protocol. I think just the Onehertz doesn't tense those muscles up quite as much, so they don't get those tension headaches.
All right, Dr. Powell, looks like we doesn't have any more questions here. So, sorry, we're getting an echo again. There we go. Well, thank you so much for coming and letting us know about TMS. Would it be all right if we could share your emails, so if people have questions in the future, they would be able to email you?
Absolutely. Thank you for having me, and those were excellent questions. I appreciate your attention.
Thank you.
You're good.
Right.
All right, we have a couple more minutes before Dr. Bossi begins, so we can take a little break. We have extra food if people want that, a little bathroom break, and then we'll get started at about 3.